Great, thank you, Tyla. Good afternoon, everyone. Thank you for joining us. My name is Brittany Lee, and I am a Policy Associate at the New Jersey Healthcare Quality Institute. The Quality Institute is a multi-stakeholder membership organization that convenes healthcare leaders in New Jersey around the common goal of improving the safety, quality, and affordability of healthcare for everyone. In a public health crisis such as the one we are facing now with COVID-19, it really tests our strengths and highlights our weaknesses. So at the Quality Institute, we are going to continue to have important conversations about today's toughest healthcare issues remotely through webinars, quality briefings, and other valuable resources such as today's presentation. We will get through this time together by communicating best practices and learning from each other. A couple of housekeeping items before we get started. Please know that this webinar is being recorded and a copy will be posted on our website, www.njhcqi.org, later today. All phone lines will be muted for the duration of the program to limit any background noise. You may ask questions at the end of the presentation by typing directly into the chat box. And the topic for today's presentation is using telehealth to maintain primary care for patients. By the end of this webinar, you will learn the impact of telehealth on primary care practice, how to build better relationships with your patients using telehealth, how to train front desk staff to triage patients using a decision tree, and how to communicate with patients about accessing telehealth and continuing to receive care appropriately. We are honored to have George Ambrosio, MD, and Jennifer Crawford, MPAC of First Care Medical Group as the expert speakers for this webinar. And with that, I'll toss it over to Dr. Ambrosio and Jennifer.
Okay, so we've given this webinar, we've given many of these webinars. Back in 2015, we gave it to Verizon, CMS 2017. So the first group of slides, I've been doing a lot lately because of people going to telemedicine. The first group of slides came from prior webinars. They were really about generally why you would do telemedicine, how we would use it. And I usually run through them pretty quickly because the second group of slides we added only in the last month had to do with the whole issue of COVID and how to deal with that from a telemedicine or telehealth point of view. We had a little longer than we normally have, so I'm going to take my time a little bit on the first few slides, but I think they'll be very illustrative. Next slide, please. So we're a little different in the sense that we have two. We have a ratio of 2 mid-levels to each doctor. We actually, this slide below, we have 4 doctors now. One of our doctors is retired, but we have 3 nurse practitioners and 5 physician assistants. And we've been in a PCMH model since 2009. We were in what's called the comprehensive primary care 2013 to 16. Prior to that, we're in other bio-based models, and now we're in CPC plus. So we've been doing a PCMH model for quite a long time, for over 10 years now. Next slide, please. Next slide. Okay. So when I talk to patients or people in general, I talk about the PCMH model. I simply try to explain it in a very simple way. That it's, in the traditional model of sick care, you are seeing people when they're sick, or you'll see them in the office, the hospital. But in the PCMH model, we're concerned about the 5,000 waking hours. They're not in the office. And all those behaviors, the 6 big behaviors, what we want to impact, we want to bring their exercise, their diet, smoking, vaping, alcohol, drugs, premature pregnancy, sexually transmitted disease, and bad decision making. Those are the kinds of things that we want to impact. And if we get people to exercise, diet, not smoke, not drink responsibly, not at all, we're going to have great outcomes. And we've shown that, and other people have too. So telemedicine is a great way to connect with people who are in their homes and in those 5,000 hours. And so it's wonderful for a PCMH practice that's doing value-based care. Next slide, please. So I only make this slide as a differential because many times when people think of telemedicine, they're thinking of the teledocs, the Amwells, and they serve a purpose. But we've always looked at telemedicine as a way to build a relationship. And in fact, telemedicine wasn't reimbursed except for Horizon. So much of our telemedicine that we did was for high-risk patients, especially in our Medicare population or other populations. We weren't paid for the telemedicine. We found it extremely valuable to help to improve outcomes. We're going to talk about a couple of case studies. So there is a difference between what we think of as telemedicine and maybe the what I would call the broader concept of telemedicine, where you're giving access sort of in an urgent care way. Next slide, please. So I'm not going to do these slides now, but they were done a while ago to just sort of, if you just click through, is it Tyler's? Yeah, just click through. These are just obvious things, and you have access to these slides, so that the idea would be that they're nice to have. Just stop there for a second. So, the docs, and this is a little incorrect now. You probably know that there's a lot of parity now with telemedicine being reimbursed. We could speak to that if you want, but I bet you all know it anyway. So some of these, but these slides are really for the general concepts, and they're very, very good, but they're not important right now. Next slide. So next slide. Okay, so next slide, please. Actually, we're going to skip this one and go to the next one. Jennifer's going to be talking next. She's been doing telemedicine for 5 years. She was with us since 2007, and I think 5 years ago is when she moved to State College, Pennsylvania. So Jennifer's our clinical coordinator and does everything in our practice from remotely, including lots of telemedicine over the last 5 years. So this is a patient Jennifer will talk to you about, but you'll see that she's very uncontrolled diabetic, and over a relatively short period of time, you can see the dates down there, she went from a 9.9 down to something much more reasonable, and more importantly, and this is so amazing that we found this out, this woman in our office was a very meek person, and when she came to our office, she was very, very difficult to even express herself, and she hardly talked. On telemedicine, in her home, she became a totally different person. And in Jennifer's relationship with her over time, when she comes to the office, it literally is night and day, and it's helped her tremendously. She has a young child, not that young anymore, he's 11, but it's really spectacular, the difference between what happens when you have a one-on-one in a telemedicine way, how that really impacts the care they get throughout whether it's in the office, hospital, whatever, is a whole different relationship. So we'll talk, our whole concept here is that it's about relationship building and keeping in touch with people. And, there's a guy named Leonard Kish, he talked about, he had a famous quote, a patient engagement is the holy grail of medicine, or something like that. And anybody, better than any drug, and anybody that doesn't use it is committing malpractice. So we do lots of ways to engage our patients besides telemedicine, but in the continuum of what we're trying to do, telemedicine is one of our most potent weapons. I'll just mention on this person, for example, she took pictures of her food, sent food in. We would see, I learned what Lunchables were, because I said, what's that? So there's lots of things you can do besides, besides telemedicine, but I'll let Jennifer talk about Susan. Next slide. So what we've mostly been talking about, and it's mostly with clinicians, is like what we've done for COVID. So in our practice, we basically we call it the prime directive now. And we said that basically we want to protect the staff as the prime directive, because I read many places that, Italy, other places, and we've seen it happen in the United States, that we could lose as many as 35% of the staff by June. And, it's difficult. We have 14,000 lives, losing staff. Now, we had a lot of older staff. And so we actually were down from a 40-person office practice, front desk, clinicians, everything. We actually was down at one point to 23 because people were quarantined, people were older, people were pregnant, people were high risk. So, and we're still down. We're up to 29. So we've lost 11 people. It's so the whole prime directive was so important for us to get our heads around that. And of course, the second rule was to maintain access to care for our patients. And so Telemed works on both of those levels. And I just print this out that's something that everyone embraced, and our patients embraced it too. Next slide. So I kept this in to say this. We have Zoom meetings. You'll see 30-minute Zoom meetings with our all staff, 6:30 to 7 on once a week. And I've made the bold prediction that this is the new normal. There's lots of reasons. I didn't put data up here that I could easily reference, and you can too. There are many sources, often from the VA, by the way, that telemedicine patients do better clinically, that it's a tremendous tool, and that basically if you integrate telemedicine into your normal practice, you will get better outcomes, both in cost and utilization. Now, we actually have changed our model of care. I believe that telemedicine is here to stay. I don't know, I'm no expert, but I am a doc and I read a lot. I follow people that are brilliant, Larry Brilliant, for example, out in Michigan. But the bottom line is that I think telemedicine will be the standard way of dealing with patients. Until recently, only Horizon in my world reimbursed. Medicare didn't reimburse, no one else reimbursed. So most of our telemedicines were unreimbursed. Now they're reimbursed and patients love it. My staff loves it, and it just works well. So I just put it up to say that I think it's the new normal. Next slide. So while we did telemedicine for 5 years, we didn't do it in the office. It was done remotely by Jennifer and two other mid-levels. And I did a few here or there just occasionally, but it wasn't necessary because I was in the office. So we had to get at that time, maybe 30 staff that had to use this. And so we did was this. We bought Chrome laptops because I wanted to try to, Jennifer didn't do it this way. She was by herself in a room, and she'll talk about that, in her house. But I wanted to recreate an environment that was easy for the staff to get the workflow, without too much disruption. So we bought a bunch of Chromebooks. They were very inexpensive. We got them for $80 and we got some for $60. So, I don't know, that's what they cost apparently. If you go on web and you have your son figure out, get the Chromebooks. You're going to see a picture of them. There's a video that you can look at. I'll reference it on YouTube that I'm in, just like a 3-minute video to show how we do it. But the idea was that the Chromebook would take the place of the patient. So when we connect with the patient, they're on this Chromebook, and that could just basically follow them around. My original idea was to have it in a room. So one room you'd have a patient, but maybe you'd have the next room you'd have a screen. But we went with the Chromebooks, and it worked out very well. Who knew that we'd hardly have any patients come into the office, so that was unnecessary. But I needed people to learn how to do it. So we made people do, we gave them a few days to do, we gave them a week, say, look, every single employee must do a telemed visit as if they were a patient. And every single clinician must do a telemed visit as a patient and also as a clinician. So they would understand the process and what goes on. And we did that, and it was extremely successful. So that experiential learning worked out extremely well. Next slide. So this is a picture, and with the red boxes are the Chromebooks, and you could see the left side is our waiting area, is our reception. On the right, the woman in the front, she's a medical assistant, X-ray tech, and she's doing the all the things she would do: medication reconciliation, dealing with tasks, talking with gaps in care, social alcohol screening, if we have PHQ-9s, GAD-7s, all the kinds of stuff that she would normally do if there was a patient in front of her. And the woman to the back, she's the nurse practitioner, and she's actually on the telemed with a patient. So you could see all three roles: the front desk, the mid-level, the medical assistant, and the clinician are just passing those Chromebooks around. And so there's a video. You can go to First Care, the name of our practice, telemedicine, and I put a 3 or 4 minute video which actually shows it, and we show a few things. So I think it's illustrative to help people see it on the video because they can see how the workflow works. But the most important thing was the staff took to this pretty easily because, you know, the Chromebook is just the person. And so it actually worked out very, very easily. We do we do 80 to 90 telemedicines a day seamlessly. And some of them are done remotely. And also because we have people working home, we have surge capacity. So for example, Jennifer could take over telemedicine at home because they're busy in the offices and something's happened, right? Or maybe or duplication. And we have other people that could do surge. So by having people work remotely, and Jennifer could talk the difference between remote and what we do in the office it's a little different in terms of the workflow. Next slide, please. So we had to figure out what to do, and so we have 8 versions of this. I think this might be the 3rd version. I'm not really sure. It might be the 2nd version. Might be the 4th version. I don't know. But the idea was that we have both a walk-in kind of practice, and many people will allow them to come in if we're not their doctor. But most of our people are our patients, and so I had a couple of ways to help the front desk figure out what to do. Next slide. So this is the 8th version, and each version that I had was to address a particular problem. And this is an issue right now. We created something called Manager of the Day because deciding who could have a sick visit is a big deal, and deciding who gets COVID testing is a big deal. It's certainly something that we found is best made by somebody who has a higher level of skill. So Jennifer and people and managers, clinical other clinicians that are managers of the day, they make those decisions. So we also did a bunch of stuff. We found that a lot of doctors were not available, and all of a sudden, because we're doing telemedicine, and we allow only our patients to do telemedicine, people that choose us as their doctor, all of a sudden, all these people want us to be their doctor. So we had to have some rules. And so you'll see, well, it's a case-by-case basis here if you follow the algorithm. And if you notice number 3 at the bottom, if the former PCP is active in the local community, we don't want we don't want that patient to change to us and all of a sudden, you know, change back. Because as you all know, in a PCMH model, when you make someone the PCP, there's an hour or 2 of work of getting their records, of updating their chart, of putting in their colonoscopies and their mammographies and all those gaps in care, and you know, it's a lot of work. So the way I explain it to the front people is that it's like getting married. You don't marry people unless you're really ready. And so we actually had to make our model go to a level where the manager of the day has to make that decision. It's worked out well. And we made some other issues. Demographics, can't have somebody from like too far away. Our offices are in Essex and Bergen, hot zones. And we do come from a wide area, and our hospitals go to 7 hospitals we have relationships with. And so that's why we can pick areas where hospitals can go. So when people go in with collaborative agreements, we can follow them in the hospital and out of the hospital, and it works out well for our transitions of care. Next slide. Okay, so this is from the British Medical Journal. I wanted people to see this. So this is not the full page. I really just took, so they have, so the Brits are a great place to look for telemedicine because they've been doing it and they have great stuff. So this is their COVID remote consultation page. And the reason I wanted to show this, and Jennifer will talk to this, I'm sure, is number 5 is the examination. You can do an examination in telemedicine. And Jennifer made sure our templates had an examination in telemedicine. How do people look? You know, are they breathing well? I'll let Jennifer talk about it. She's done it many more times than I have. I'm a novice actually compared to her, but you can learn a lot. And of course, with our world, we want to see those red flags. You can see when someone's breathing poorly. They can hold up their blood pressure cuff or their pulse ox or whatever it is. You can get data from them. You'll see at the bottom there, you know, we have our patients, she'll explain, they take their blood pressures. You know, in a PCMH world, they know what they get and their blood pressures is way more important than we get in the office once in a while. So every one of our patients is taking their blood pressures, their blood sugars, if they're really in the PCMH model, because we harangue them otherwise. So next slide. This was, I put this out there because our staff was having a hard time of figuring out who does what. So this was our way of letting them know about, routine office visits, annual wellness visits, and transitive care. I just want to make it so you could see our first option, and you could see, if you notice, our second option there. If somebody needs a physical evaluation, somebody's a potentially serious problem. I've had, just to give you an idea, somebody had a what's called homonymous hemianopia. He couldn't see out of the right side of his either eye, which is either a stroke or a bleed. So he walked in. He didn't say it was wrong. The person who scheduled the appointment knew that he was acutely a problem. He came in and we sent him to the hospital. Thank God it was a stroke, not a bleed. That's an example. Or somebody's got an A1C of 10 and they haven't been in for 6 months, so they have to call now. Yeah, they got to come in, And of course, when they would come in is during our well appointment time. But our first choice is usually telemed, except for, people that need to come in. Next slide. So this is just a slide for us, again, for the clinicians. So we've had the PPE. We were very aggressive in making sure that we have full PPE, and we do COVID testing in our parking lots at 4:30 in the afternoon, and it's worked out very, very well, and we're getting good, quick results. So we usually get them within 24 to 36 hours. And that's worked well. And now we're thinking about going with the IgG test with Abbott. We haven't decided that. There's issues there in terms of false positives, false negatives. I'm trying to figure that out. But in any event, I showed that because that was really important. You'll notice that sign said immediate medical care. Go to the next slide. So patient communication is really, really important. You're welcome to go to our website. We usually get a lot of good positive feedback on it. It explains a lot of stuff. We have our phone auto attendant also is very, very changed. We changed it. By the way, there have been many iterations of this, many, including our website. We think all of our workflows now, because of COVID, we're getting to where we think we're really comfortable. We send out blast emails using constant contact to educate people about certain things, and they've been very effective. We have blast text capability. And then blast phone calls we haven't done because just only 24 hours, how many hours in the day? We can do that with our software vendor, but we haven't done it. Next slide. So we changed our sign very quickly we took away all that immediate stuff, don't come in, call ahead, but we put same-day telemedicine appointments, which we do. We do our telemedicine Jennifer will talk about when we do them, because that's interesting. She'll tell you when we do them. She does them all hours of the day or night. Next slide. I just put this up to show people that we had to change the signs on our door, and you'll notice that the green one is telemedicine. We really focus that's what people should be focusing on. We make $0 copay. Now, we did that initially, and now, of course, many of the payers don't have a copay with Telemed. We write it off if somebody doesn't. We think access to care is important. If our patients lose their insurance, we will carry them for a year. We charge them $60 for a visit. If they can't afford it, we let them go, because these are our patients. We've known them for a long time, up to a year. Otherwise, we plug them into an FQHC or whatever we need to. But hopefully that won't be necessary. But we are really concerned. But that green, that Telemed is really something we really promote, and it's been very successful. Next slide. So I'm going to turn it over to Jennifer right now. Jennifer will talk about her experience, and she'll fill in a lot of the details because she's been doing this for quite a long time.
Okay, so as Dr. Ambrosio mentioned, I have been with First Care for a long time, and when I relocated, we actually used that as our opportunity to launch our telemedicine program. So that was in 2015. So in 2015, we started doing telemedicine visits, and initially for our first launch, we, as a practice, kind of cherry-picked what patients we thought we can have the most benefit for. So in doing that, we picked those high-risk, complicated patients who were historically non-controlled, diabetics or overutilizers to the ER or to the practice. And in doing so, we were able to kind of track them over time to show what impact forming stronger bonds or relationships and doing those telemedicine visits had with those particular patients. So the one slide that you saw earlier was a patient, Susan, as Dr. Ambrosio had mentioned. She was always a non-compliant diabetic. She would come to the office when she needed to for blood work. Often she was a little late having those tests done. When she would come in, she would barely speak. She would hardly have any interaction with the providers. No matter who she saw, you could get very little information from her. So anytime her blood work would come back, the staff used to complain about calling her because it was horribly frustrating, because she wouldn't listen to any of the recommendations we were making, and her A1C was consistently 9 to 10. It never dropped really below that. So we reached out to her. I started doing telemedicine visits with her, and she became a totally different patient for our practice. As I mentioned, in the office, she never spoke. On telemedicine, I can't get her to stop talking. I think there's a very big difference when you see patients in your office versus when you see them in their home. When they're in their home, in their environment, it does change the dynamics of your conversation. And it also does allow you to establish a more meaningful relationship with patients. And you also don't only get the patient's perspective, but you get the perspective of their family as well. When I'm telemeding with her and she's telling me, as an uncontrolled diabetic who's grossly overweight with heart failure, that she walked today, and her son, who's 11, says, "No, you didn't, Mom. Like, you didn't do that. You only walked the dog to the door or something. You didn't go outside." And so it just does give you a whole different perspective on patients, and that relationship does change pretty drastically. I met with her regularly in the beginning to change her diet and behavior. We were meeting once a week. We eventually spaced it out to once every 2 weeks. We got to like once a month. And then I started alternating with Dr. Ambrosio. So she would come to the office and see him. And if he said, "Okay, I'll follow you up in 3 months," I would see her on the 6-week mark in between. At one point, I actually went on maternity leave, and she stopped doing those telemeds with us. We had other providers available. She wasn't really into it. And you can see that her A1C started to climb back up when we stopped doing those frequent check-ins. She has a personality that she needs to be held accountable to somebody other than herself. And so when we stopped meeting with her, you found that her behavior went back. She reverted. So now we do telemeds with her, like I said, in between office visits. So she'll see Dr. Ambrosio every 3 months. I see her every 6 weeks or more often, depending on what her needs are. But she's back on target. A1Cs are controlled. And we do actually have insight into what's going on in her day-to-day life, where before we had no idea what was going on. Another case study that we had done was on a patient who was an overutilizer. He would call the practice every day. He was really a hypochondriac, would go to the ER all the time, had unnecessary testing done all the time. Crazy things. He's a young guy. They were giving him stress tests. At one point, he had an MRI of his brain, and they found an incidental lesion that caused a huge problem for months of us trying to convince him that everything was okay. So we started doing telemed check-ins with him, just to kind of curb his anxiety and to make sure that he had a touch point with the practice. I can't remember how many ER visits he had that one year. Dr. Ambrosio might remember. But we literally, you're muted, Dr. A.
He had 14, and we got the information from the Horizon. They spent over $200,000. He had multiple admissions in 2013, if I'm not mistaken.
Multiple ER visits with unnecessary tests, crazy unnecessary tests. And so we decided to telemed him for overutilization. And with him, I would meet with him the same kind of thing, like once every 2 weeks, eventually spanned out to once a month. Now I have to call him to say, "Hey, we haven't talked in a while. Like, don't you want to meet?" So we were able to completely reverse his horrible behaviors. He went from going to the ER 14 times in a year. He didn't go once the entire next year once we started telemedicine, and he hasn't had any ER visits since then. So just having that stronger relationship to the practice where he knows that he can call or he can reach out, or we'll see him on telemedicine in his own space, in his own time, has really, really helped transform his behavior as well. So initially, we targeted telemedicine for these high-risk overutilization kinds of patients to strengthen their relationships with the practice, and to prove that with stronger primary care relationship, you can influence behavior, which will heavily influence spending. Now, in light of COVID, obviously things have changed. So Over the 5-year window for the practice, again, we mostly cherry picked who did the telemedicine visits, who we were offering those services to. We never really advertised it for our practice. Patients would kind of get through to me as a manager to say like, hey, you need intervention here. They need your help. Obviously with COVID, things have changed and we've started now advertising for telemedicine. And we've trained the rest of the providers that are in the office to do telemedicine since our office volume has dropped off substantially. But in doing so, patients love the telemedicine experience. We've not had anyone say that they don't want to do it again. Most of our patients are good about self-management. So people with hypertension and diabetes can still give us data. We're getting blood pressures. We have patients who are on oxygen that have pulse oxes in their home. So we're able to still gather those types of, clinical data elements that we need for charting purposes. The other thing that we spent time with in terms of training for our providers is that there's two things. One is that I think we tend to underestimate patients' abilities. So when we were first moving from office visits to telemedicine in light of COVID, we're going to encourage all these patients now to have online visits instead of coming to the practice. Everybody, almost all of our providers unanimously said, well, my 70-year-old patient's not going to do this. So I think that we tend to underestimate patients' capabilities. I think that most patients now have smartphones or an iPad or some kind of tablet at home. And most of the telemed vendors have apps that make them relatively easy to use. So we've hardly had any patients have difficulty accessing our telemedicine platform. I've done them on 80-year-old people. We do have one patient with dementia who couldn't get on themselves and their son was able to intervene and help set up the telemedicine visits. So the first thing that we had to kind of break through with our providers is don't underestimate your patient's abilities. I think a lot of them have a lot more technology capabilities than we give them credit for, especially now with COVID. They're online on Facebook chatting with their grandchildren. So I think they have more capabilities than we think. But the other thing too was your ability to do the assessments as a provider. So when you have that face-to-face interaction with the patient over the internet, you are able to form very valuable assessments. It also gives you, because the patient is in their home, the ability to truly drill down on things that you may not have had opportunity to do before. So, we have patients a lot that'll say, oh, I had a blood pressure medicine that the cardiologist gave me a sample. I don't know what it's called. When they're in the office, how are we going to find that out? But now that they're in their home, they can walk over and get the medicine and show you what they're taking. So it's been very effective for med reconciliations. It's very effective for patients who you're concerned about occupational therapy needs. Are they getting around their house okay? What is their living situation like? Is it all on one floor? Do they have to do multiple stairs? What kind of food is in their fridge? Do they have access to the things that they need? So it actually gives you, I feel like it takes you back to your medical school days, right? Where the history is the most important thing. And on telemedicine, you can actually take incredibly good histories with patients because they're in their own area. You can have more detailed information from stuff that you would not be able to get from the office. So we've actually found it to be very, very valuable. And our practice has made the transition pretty seamlessly from office visits to telemedicine. Our office volume has dropped off markedly with COVID because of us, because we're encouraging patients to do telemedicine instead. But our telemed volume has soared and patients are very, very happy with it.
Great, thank you, Jennifer and Dr. Ambrosio. That was really helpful. Now that we transition over to our question and answer segment of today's webinar, I have a few questions that I wanted to pose to our speakers, but for those of you that are participating, if you have questions, please feel free to type them in the chat box and we'll get through as many as we can in the time that we have allotted. My first question is for Dr. Ambrosio, and the question is, how has COVID changed how your practice uses telemedicine?
I think, again, we used to use it as a targeted way. It wasn't reimbursed, to be honest. I mean, if it isn't reimbursed, we want to use it, but we can't afford to use it unless it's going to have outcomes that are going to make a difference in terms of the amount of resources we're going to align. Now, all of our resources are that. Every single person everybody, the front desk, everybody's all about telemedicine, and because it's reimbursed. And so it's simply a matter of, we would have loved to have done this earlier, but without it being reimbursed, it economically wouldn't have been viable. You would have, when they came in the office, you got paid. When they didn't come in the office, you didn't get paid. So some of those people that Jennifer was talking about, we did that without getting paid. But it was important because we were getting rewarded in a different way. Our outcomes, we always are a high performer. We get high grades on whether it's with the United Healthcare STARS program or whether it's with CPC. We always get every program we're in, we get very high grades with, and this is one of the reasons you can do it. But now they were getting paid. There's no reason not to do a telemedicine visit. I really don't, unless the patient has to come in for clinical reasons. But I would think that would be the first choice of everybody.
Great, thank you. My next question is for Jennifer, and I think you touched on this a little bit in terms of not underestimating a patient's ability to use technology. I'm curious if there's any other type of assistance that you can provide to patients that are having trouble accessing technology.
So pre-COVID, in our pre-COVID ways, we were actually trying to launch a program where we were going to send our medical assistants into the homes of patients who had higher risk problems, who needed more touches with the practice. So we were actually designing a program to send our MAs with an iPad out to the patient's home, where they would then connect to the provider, and the MA would be in the home to help the patient use, a practice supplied iPad to figure out how to face-to-face visit with some of those higher risk patients. We've had to kind of put that on hold, obviously, with COVID. We don't want to send anybody out into other people's homes right now in the communities, but that had been our plan to help some of our older patients who may not have access to technology. Our vendor, thankfully, that we chose for telemedicine years ago, allows you to do telemedicine visits either on a computer with a camera and microphone, or there's apps available for most smartphones and tablets. So we've had very few patients not have the ability to connect if they want it.
But we do offer telehealth or telephone visits too.
Telephone, right?
And
exactly.
we
have a robust patient portal, which also is very key to being able to integrate telemedicine visits well. Because if I'm doing a telemed visit with a patient and they need documentation, or they need data, or they need patient education forms, they all have patient portal accounts, and I'm able to send that information over to them electronically as well. So having that additional technology also is definitely key to support your telemedicine success for your practices.
And we have other technologies that people can use. We can text them or email them forms outside the portal, which they can fill out and get it back to us securely. As Jennifer mentioned, it's sort of I'm shocked at how many people that are in their 70s, 80s, and even 90s that can get this done because they have help. They have people to help them, and some of them don't need help. So the world today is people are used to digital things, and so they really appreciate it. But when people really have a difficult time, we switch them to telephone, which is on our spreadsheet. If you go back a bit, Tyler, to one of the colored spreadsheets, the decision trees.
All the way down at the bottom, it's like one of the very last slides. That one, yep.
So if you look, no internet, schedule a telephone appointment, and there's codes for that, and that's by minutes, over the week. So if we call somebody 3 or 4 times in a week, and let's say we spend 5 minutes each time, we've called them 4 times, that's a 20-minute, call. You bill it that way. It's per week on the phone.
Great, thank you. My next question is for both or either of you, and it sounds like there's a lot of really great supports to help facilitate the telehealth appointments and ensure ongoing care for patients. And your practice obviously has a really close relationship with your patient population. I'm wondering if you have any advice for providers who are having a difficult time encouraging their patients to continue to seek either necessary preventative care or care for chronic disease management during this difficult time.
We've worked very hard, as you can see in our algorithms, to make sure that our office is segregated, that we have well patient hours, and that the patients that we see for well visits are made aware that we do screening. So if we schedule an appointment for a patient 3 days from now to come in because they're diabetic and they need their blood work, the morning of their appointment, our front desk calls to verify that nothing has changed, that you still don't have any of these symptoms for COVID and you still haven't been in contact with someone who's potentially an issue. So as Dr. Ambrosio mentioned, our phone trees have been edited sometimes daily or multiple times a day to get that data out to patients so that when they call the office, they're hearing like, we've done the things that we need to do to make sure that it is safe for you to come to the office if necessary. So if you do have to have blood work done, if you are due for your annual wellness visits, COVID's not going away, right? So this has been going on for weeks and there's no end in sight. So you need access to your office, and we've done the things that we need to do to make sure that you still have that access. We don't allow sick patients to come in during well time at all. They come in after our office has already closed. And then at the end of every day, our office is sprayed down with Aseptic Plus to make sure, we fog the room that the sick patients are in to make sure that our patients are actually being protected. So we've done a good job at delivering that message to our patients, both on the phone tree and when making phone calls. And they are also getting that reinforcement when we're calling them the morning of their appointments to say like, hey, we want to make sure you still don't have any of these things. We do encourage telemedicine first line for most patients for most things, unless, as you saw on the other slide, if they're due for blood work and they're diabetic, then they have no choice but to come to the office. And I think that the patients feel safer coming to our office for the blood draws than they do going to the labs when they don't know what type of measures are in place to protect them from infection.
Great, thank you both. Those are the questions that I have, but I'm going to toss it over to Tyler now to read out some questions that we got in our chat and Q&A boxes, and feel free to kind of keep them coming in for Jennifer and Dr. Ambrosio.
Great, thank you. Yep, we got a couple of great questions so far. I'm going to run through as many as I can. So first up, probably for Dr. Ambrosio, why did you choose Chromebooks instead of using your existing laptops or desktops?
So laptops, we have laptops, not laptops, tablets that we use, and we have desktops, but that's stationary. The idea was the Chromebook is a way to replace the physical patient. I was trying to do, so Jennifer will tell you, maybe you want to take this, Jennifer, because you don't use the Chromebook.
Yeah, also, so we have multi-screen setups. So that's really why you needed the extra Chromebook. And maybe I should have alluded to that in terms of our workflows. So when we sign into Chiron, which is our telehealth vendor, the only thing that Chiron is for us is that secure face-to-face connection to the patient. So that's what's being loaded onto the Chromebook. In my home office, I actually have 2 screens. I have dual screen set up. So when you're on the Telemed with the patient, you're face-to-face with them, but on your regular tablet, you have your EHR. So we have Greenway up, so you're in the patient's record. So you're doing all the work as if they're in the office with you. So we're updating everything that we would if they're in the office. We're reviewing allergies, meds, social history, tobacco, alcohol, updating any screenings that are due. So their social screens, their PHQ-9s, their GAD-7s, that's all getting done while we're on the telemedicine visits with the patients. We try to make, as I kind of mentioned earlier, I feel like you have to rely very heavily on a lot of your histories, but we try to make telemedicine visits really all-encompassing. These are our patients. So you want to make sure that even if you're seeing them for COVID concerns or somebody has a sore throat, that you're addressing their diabetes, their hypertension, their hypothyroid. You didn't have your PHQ-9 or your GAD-7 yet this year because you haven't come for your annual wellness visit. So all that's being done. And the way we've been able to do that is to have that dual system. So the Chromebook is just your face-to-face connection to give you that opportunity to see the patient, but you're still working in your tablet to go through all your EHR, questions and checklists and templates.
Let me just add to that. So some of our doctors are older. All of us are older, actually. And so it would be very difficult for them to have to do everything. So this allows them to basically, the front desk does their thing, like they always did. The medical assistant does their thing. And when the doctor's given the Chromebook, it's like giving the patient. And so the doctor just stays within their sphere. Jennifer does everything from home. She has to do everything. She checks them in. She does all the whatever you're supposed to do that I don't do. So it's again, it was a way, the Chromebooks were a way for us to replace the patient with a physical piece of equipment, but have the doctors and all the staff not change one iota of their normal workflow.
That's great. And Dr. Ambrosio, I'll send out the link to the YouTube video that you mentioned, because I think that's a great visual for how, you know, folks are moving the Chromebook from place to place as if they were a patient.
Thanks.
Good question. A question on billing. In terms of billing, are we allowed to see a brand new patient on telemedicine? If so, how can we bill it? There is no option to bill a 99203 with a 95 modifier.
So Jennifer, you take this one, because this was an issue, and I'll bring it up. So we had multiple iterations of this, right? So we had a woman that called. Jennifer called me. She says, I've got a woman that called. She's 36 years old. She goes to an OBGYN. She doesn't have a primary care doctor. She went to a drive-through, and she's a positive COVID. She doesn't have a PCP. And she hasn't been here ever, right, Jen? Was she ever here?
No, her husband is our patient.
Yeah, and her husband's our patient. What are you supposed to do? That's well, our requirement is on our former one that she had to come into the office because we don't see new patients without a physical visit. But she's positive COVID. So what do we do? Jennifer, tell her what we do, because we got to come up with some solution.
So the answer is you're not supposed to see patients for the first time on telemedicine. No, you're supposed to bring them to your office. The answer for billing and their recommendation is no, you do not do it on telemedicine. It's established patients. It says very clearly in their reimbursement policies it's for established patients. Our practice had to make a decision about what were we prioritizing. Were we going to prioritize the health of our staff, or did we we basically had conflicting mindsets. So we made a case that the patient should come to the office, right? Because they're new. And the first time you examine that patient on telemedicine, you're basically assuming that the baseline physical exam is somewhat normal, right? And these are all patients you've seen before. So you would know going through your medical records if they had any underlying issues. For new patients, you're taking on that assumption that your physical exam is normal, and you don't know that because you've not examined them previously. So our initial policy was that anyone who was new to the practice had to come in. We were scheduling them 6 visits after hours to come in and see the providers. The longer this went on and the busier we got and the more COVIDs came back positive, the more we started thinking like, geez, we're really risking our providers by making these people come in. And so then this patient comes across who has COVID. We know for sure she has it. And so we had to make a decision. Are we really going to risk the health of our providers now, knowing that she has COVID, making her come to the office? Or are we going to do the right thing for the patient and see her on telemedicine and tell her when this all goes away, we will bring her in then for her annual physical and do that. So that's what we've done. She's been treated just like any of our other patients. Our COVID workflow is that we call those patients every day by phone, and we see them on telemedicine every 3 days. Their status can change very, very abruptly. We've had multiple patients require hospital admissions. And so our staff works every day to contact every one of our COVID patients or COVID suspect patients by phone, and we telemed them every 3 days. As far as billing, you know, we talked to our billing manager and said, if we need to, we'll eat the cost. I mean, what are we supposed to do? Bring a known positive COVID in to see Dr. Ambrosio, who's high risk himself, you know, to expose our staff. So we made a decision to prioritize the health of our staff and then to do the right thing and bring her in for her annual physical, you know, after she's considered recovered.
Great. Thank you. Another great couple of questions from our board member, Dr. Campagnolo from Virtua. She asks, what platform are the patients actually connecting to in order to have the visit? How do you give them the link? Do you call them first? And then what about the HIPAA security of PPI after COVID-19 relaxed rules are over?
So our vendor that we chose back in 2015 is Chiron Health, and they are integrated into our Greenway EHR. So thankfully for us, we've been live on Chiron for a long time, and we already had an integrated solution. So our front desk workflow does not change. When the patient requests a telemedicine visit, they're scheduled within Greenway, our EHR, as a telehealth, as a telemedicine location. When that happens, that trigger actually crosses into Chiron's database. So the appointment that we scheduled in Greenway is now pushed into Chiron, and Chiron themselves sends an invitation email to the patients. So the minute the appointment gets scheduled, Chiron generates an invitation email that the patient will receive that encourages the patient to create their account before the visit. So if I schedule a visit for next week, you're still going to get that email today prompting you to create your account. Chiron then does follow-up reminder emails for the patients. We do too, but Chiron actually will take on that responsibility for practices and send out those reminders. They even message the patient within like a 10 or 15-minute window before your visit to say, hey, remember, you're supposed to be signing in. Here's the link to get back to your account. Once the patient has created their account for that first visit, they can just log into their account anytime and see any future appointments that they have scheduled. They can use those accounts to create additional, appointment requests for the future. And we have a great landing page that's a link on our website that patients can request telemedicine visits from there as well. So thankfully for us, it's an integrated solution. The patient gets the email from Chiron as a prompt to create their account, and then they just sign back into those same accounts every time. It's also HIPAA compliant, so we don't have any issues with security.
Okay, great. Thank you. That's very helpful. I know I had a couple more in the chat box here. For pediatricians who need to give immunizations, is there a way to do part of that as telehealth and part of that in the office? How would you bill for that? And for instance, you get the history, discuss growth, development, and diet on the phone, and the patient comes in for the vaccine at a different time. Is basically, I think they're asking, is that possible, or would you take that approach?
We've kind of done something a little similar. Like if we have a diabetic patient who's high risk, say they work, at a medical office or for New Jersey Transit or something, we'll do the visit online, like the Telemed visit online for their diabetes, and then just schedule them to come to the office for a separate blood draw. So they'll come in just to have blood work taken and leave, so they're not really in the office for an extended period of time. During our revamp of these reiterations, we had talked more about making patients come in when they're due or overdue to have the blood work done and just seeing them in that capacity. Just because our telemedicine volume has been so high that instead of trying to duplicate visits or services, if they're already coming to the office, doesn't make more sense just to do the visit then. As far as the vaccines go, I'm not sure, Dr. A, do you think you would just charge a nurse visit for that day to fill out the vaccines?
I would ask Denise, but I think that's what we would do. But on the other hand, we've talked about this, the idea like, why not just bring them in? If
they're already coming.
If they're going to come in for blood work and they're healthy, you might as well just see them in the office. Now, if they're reluctant, I can understand that too. But we're not seeing a lot of people in the office. We're seeing 1 or 2 an hour. So it isn't an issue. But I guess with pediatricians have to give lots of vaccines, it might be something you might do where you get them in and out. I don't know what the best way to do that is. I think it has to do with the volume. It's all about volume, how many people you have to come in, how quickly you get them in and out. I don't really know.
Great. Sort of a similar question, sort of piggybacking off of that, for annual well visits, would you postpone them during this time, or would you try to do them over telemedicine or ask them to come in? How would you handle an annual well visit for patients who are comfortable approaching it right now?
So there's 2 different things when we talk about adult annual well versus annual physical exams. Annual
you go back to that screen. You go down a couple of screens.
That will go up one. Number 20. You want number 20?
There you go.
Annual wellness, when you talk about an annual wellness exam for Medicare, does not require a bulleted physical exam. It requires a blood pressure and a BMI, which is a height and weight, and multitudes of screenings and conversations about prevention. Our practice has done Medicare annual wellness visits on telehealth, and we have been reimbursed by Aetna Medicare Advantage for doing them on telemedicine, but we've recently billed Medicare and we're waiting. I've asked our billing department if we've been reimbursed for them or not. There's some question as to whether or not they're reimbursable on telemedicine. Aetna Medicare Advantage has paid us 100% for our Medicare annual wellness that we did for an Aetna Medicare Advantage patient online. That being said, the patient has to have the ability to give you their blood pressure and their weight for the visit in order to be able to meet the requirements to do a Medicare annual wellness. Annual physical exams for the commercial payers cannot be done online. That is something that requires a full bulleted physical exam. So we've made distinction for our practice so that they understand when they're scheduling appointments that if it's an annual physical exam, it has to be done in the office. If it's a Medicare annual wellness visit, that can be done online, provided that the patient has the ability to take their blood pressure and their weight for that date of service. We have no problem doing the Medicare annual wellness online. We do all this update information, you know, the PHQ-9s. Like I said, I mean, that's part of our integrated workflow. So I think that works seamlessly if the patient has the ability to give you vitals.
One comment though, Aledade, we're part of, has a position that they take no position on that. So that's something where,
because no one can confirm yet that you get paid, that you're getting reimbursed on it.
well, we bill it the proper way. We bill it with annual wellness, whatever that's supposed to be billed. So they know we're doing it as a telemed visit. Now we have to find out whether they're going to pay us.
Right.
Got it. And I think we have one more question, and then if folks have others, we'll try to get to them. If you want to enter them to the chat box, we only have a few minutes left. One last question. Do you have any internal protocol for the patients that you've not seen in a long time? So if you haven't seen them physically in the office, and maybe you don't have the capability of seeing them in the office right now, are you proactively reaching out to those patients as well?
So Jennifer could take this, but we're a PCMH model, so we have lots of task lists. And I guess Jennifer, why don't you say what some of the stuff we do?
Yeah, so even pre-COVID, you know, we have lists that are run on a monthly basis for targeting different populations of patients. Last week, we just finished up a list with diabetics who are overdue for their A1Cs to be done. So we're always running through, you know, who has blood pressure, whose last visit was high. We do med management monthly on different things. So who's diabetic and needs a med review and should be coming in, who's on Coumadin, who needs to have blood work done. You know, that kind of stuff is
hospital
all,
TCMs,
right,
you know, hospital
still happening, high-risk patients. So we have maintained that workflow, and we are still reaching out for patients. I think one of the big things in terms of the balance is that we do push telemedicine as the first option. We try heavily to encourage patients to do that. But at the same time, we recognize that not all things can be done that way. And so we have to then send that message to the patient that it is still safe to come to the office, that we do want you accessing medical care. We don't want you postponing, because how long are we postponing for? No one has an answer for that. So we don't want patients saying, oh, I know I'm due for my annual wellness visit, but I'm not coming for the next 6 months, when something could be wrong, or, you know, my blood pressure was high last time and I'm not comfortable coming back today. So we've done a lot of work to make sure that our patients understand that while telemedicine is our first choice, if you do require an office visit, it is safe for you to come to our office. We've gone through those measures to make sure you can still access care here on site.
Great. And I think I don't want to be respectful of everybody's time. So for folks that have other questions, thanks for giving us your contact information to give to everybody. And we'll make sure, like I said, that everybody has access to the recording of this presentation, as well as the slides, if that's okay with you. We'll of course post them as a PDF there for everybody. Also wanted to draw everybody's attention to a resource that we created at the Quality Institute as a guide to telehealth in New Jersey. So this is sort of some of the things that you mentioned. Who is reimbursing for telehealth, at what rates, what are the inclusions, exclusions. This resource is available on our website, along with a number of other COVID-19 related resources. We're creating new ones every day, and certainly doing many more of these webinars with content experts on many different topics. So please use the link at the top there, QI COVID-19 resources. It's also on the top of our homepage to access the resources that we've created already and check our calendar for upcoming events. We don't have registration available yet, but in the coming weeks, we're going to be taking on topics such as pharmaceutical care, how to work best with your pharmacist and make sure that you can access your medication. Also working with AARP on an opportunity for telehealth for seniors. Like you mentioned, don't underestimate the ability of seniors to be able to use telehealth as well. And also a number of other great topics like physical therapy. How are folks accessing and using physical therapy to stay well during this time? So a lot of interesting stuff, and I hope folks will take a look at those resources. Wanted to thank Brittany, Dr. Ambrosio, and Jennifer for participating today. It was a great presentation, and we really appreciate your expertise.
Thank you for having us.
Thanks so much.
Everybody stay safe.
Thank you. Everybody have a
Bye-bye.
great day.